no financial no financial arrangement related to the content of this activity. And we're going to talk about the team-based approach, why it's important, what it involves, what are the team members recommended for an office-based buprenorphine program, briefly going into roles and responsibilities of each team member, and kind of ending with just a little brief note on how administration can support building a team and going forward. So for me, I was sort of reviewing this presentation, sort of, going over this. I was trying to review this presentation, and what really, the importance that really came up for me was really around relatively limited resources that we have, right? We often talk about this, that, there are still, we have much more need for more prescribers, more clinicians who are prescribing buprenorphine, who are treating opioid use disorders. There are significant shortages, as we often talk about, just of behavioral health providers around New Mexico and around the country. So I think that's really where, for me, the team-based approach really becomes important, because then we can really try to leverage whatever limited resources we have to hopefully provide comprehensive care to an individual. So Dr. Lindsay here starts with the note on treatment teams, right? And I think it's a point well taken that SAMHSA really has made it and considered it best practice, that integrated treatment, where people from various disciplines, kind of like what we have virtually here, right, on Project Echo and in these Echo sessions, here, where we have primary care docs and emergency room docs and, peer support specialists and therapists. And, we've got kind of a full range of individuals. When people work together, outcomes improve, especially for all chronic illnesses, right? But here pertinently for people with serious mental illnesses along with co-occurring substance use disorders. And it is considered the gold standard treatment approach by nearly all regulatory bodies. And the idea then becomes that a client who is seeking care to receive this coordinated care that addresses multiple aspects of what might be important to them under one setting, under an integrated setting, in a consistent and coordinated manner. So it's probably intuitive, right, to think that that's likely to improve outcomes, and certainly research bears it out. A little note between multidisciplinary and interdisciplinary. We often hear those terms used interchangeably. Multidisciplinary just means that there are all these different disciplines that are doing their own thing, right? But when it's truly interdisciplinary, there is intersection between all the different expertise, all the different professions, where everyone is working together towards the same goal. And that's really what we want, right? Beyond just multidisciplinary, we want to get to interdisciplinary coordinated care. So let me pull these up. There we go. Okay. So a little note on how treatment teams can support the concept of recovery. Recovery, there's a robust and actually really engaging literature out there about recovery. It's been, I've heard it defined as sort of reclaiming one's life, has been one word I've heard. SAMHSA says hope for the future is the centerpiece of recovery. And other key pieces of recovery are things like health, physical and psychological, stable place to live, meaningful involvement in the community, a sense of purpose, support systems. All of those things play into recovery, right? So recovery just goes well beyond just remission of the substance use. It really starts to explore meaning and purpose in a person's life. And we try to support that as we treat an individual. And it's really important, I think, to know what the patient's goals are, what the patient's hopes are, intentions are, and ensure that everyone who's working with the patient, the entire treatment team, is working towards realizing those goals. And I mentioned that we start with, talking to the patient about what their goals are, what their intentions are. And I think that's super important, right? I once, had a patient sort of say, I know that I'm the captain of this ship. And I loved hearing that. The patient is absolutely correct, right? I want the patient to have that ownership of the treatment plan. Because if they don't have it, there may be less engagement, there may be less buy-in in whatever plan we've created. And that's just not going to work as well, right? As opposed to when the patient feels ownership and agency in their own care. And for me as a clinician, I may be a subject matter expert, but I'm certainly not the expert in the person's life. The patient is the person who is the expert in his or her, their life. And I really want to start from that position. So I think that's important, right? Note to start with that the patient really is at the center of this treatment team, of the treatment plan, and others come in as needed, supporting those goals. And as a clinic, as agencies, it's important to create infrastructure to promote team cohesion and allow the team to work together to do clinical work, right? And this might be different from agency to agency, depending upon staffing, depending upon other factors. And there's an expectation that treatment teams use the treatment plan as a fundamental underpinning for all clinical encounters and interventions, kind of knowing where we're headed, knowing what the plan is. And the piece I would highlight here is that really the patient should be guiding that treatment plan to a large extent. So what are the components of a successful team? So I think here we've broken it down into a core team and an extended team, right? The core team certainly includes the client, as well as primary treating providers who work with the client, that immediate group that's working with the client. And then the extended team is going to be people who are brought in depending upon the client's need. And that may be within the agency where the client is receiving care, or it might be connecting them to other outside agencies, right? It can also be other individuals like significant others, community members, etc. For a team to work, work well, I think there's a balance. It's got to be well defined. Each person's role must be well defined. People should know what's expected of them, and at the same time, there should be flexibility, right? So it's this balance between the two that really helps create a successful team. I think some key concepts: there must be a team lead, a team manager who's responsible for the treatment plan and kind of bringing together the team, facilitating communication, etc. There should be a coordinator recovery coach responsible for organizing the team meetings communication, right? And making sure everything is being tracked, all the documents, etc. And as I mentioned, there should be flexibility and at the same time, clear definition. So let's start with the team lead. Could be many different professions. Right? And this is the consistent point of contact for patients. This is the person who's really reaching out and connecting with the patient and is really coordinating a lot of these pieces, making sure the team functions as it's designed to and intended to. May also have some patient care functions. In fact, in many models of multidisciplinary care that are out there, the team lead also has quite a few patient care functions. And may also help with support and education groups for the program. Historically, nurses have been the most frequently utilized and studied in this capacity as the team lead, because they're often able to step into these multiple roles. And in many of the models, it's been registered nurses who have served as the team lead, right? But there must be some team lead. Recovery coach, engagement specialist. I think there's can be certainly RNs, where MAs, medical assistants, CHWs, peer support specialists are often ideally suited in this role as a recovery coach. And again, in many of these models that are out there, and there are several, peer support specialists are often utilized in this role as the engagement specialist or recovery coach. Does require some training to step into this role. These are some important functions, right? Lots of administrative duties, prior authorizations, which we know can be a major challenge depending upon where we practice and what we're treating. Some patient care like maintaining patient logs, checking PMP, some clinical duties, again, which might require some training. At our clinic here at the University of New Mexico, medical assistants are often utilized in this engagement specialist role. So that's something we're often doing, right? And patient education. I think this is often where peer support specialists shine with that lived experience and that ability to form that rapport. There's a significant harm reduction piece. And again, that's serving as an interface between the patient and the rest of the team, and providing ongoing psychosocial support, checking in. How are you doing? How can I support? How can I help ensure that you have the services and the referrals you need, etc. Right? Possible referrals can be made by anyone in the team, right, when it's identified. And these are just, again, going to depending upon the patient's needs. It can include things like 12-step, right, traditional healing modalities, crisis phone numbers, right, harm reduction, syringe exchange, overdose prevention, Narcan distribution. Now, this might be within agency ideally, but if not, it can be elsewhere as well. HIV and hepatitis testing and treatment, right? It always helps to know what the resources are in your community, and how to best connect the patient to those existing resources is very important. And this is really going to depend upon the patient's needs. So then a therapist, it really is recommended, although not required, that all patients on buprenorphine receive some degree of psychotherapy. One of the things that I certainly like to say is that while for opioid use disorder itself, the medication really is the centerpiece, and that really is what's shown to improve outcomes. Opioid use disorders often do not happen in isolation, right? Individuals with opioid use disorder are significantly more likely to have other substance use disorders. They're also significantly more likely to have co-occurring psychiatric illnesses and other psychosocial factors that contribute to their opioid use disorders. And for many of those, psychotherapy is essential, right? So for example, if someone has opioid use disorder and post-traumatic stress disorder, we know that treating the two in an integrated manner is going to improve outcomes. And we also know that for something like post-traumatic stress disorder, trauma-focused psychotherapy is key. It is, more effective generally than medications, and patients accept it more. So I think that's why, it really helps to have that available. And I think the other key piece there with psychotherapy is that we don't want one size fits all. We really want to connect patients to psychotherapy that's going to work for them, that's going to address their specific needs. And there are many evidence-based psychotherapies that might fit the bill here, right? Including cognitive behavioral therapy, relapse prevention, motivational interviewing, contingency management. Consistently one of the most effective forms of psychotherapy in patients with substance use disorders. 12-step facilitation, which was specifically designed to help enhance participation in 12-step. And if you have those resources in-house, awesome. But if not, the outside referral can also happen. We kind of move forward. A pharmacist can be a critical ally. There's so much new information coming out in the pharmacy literature about what the role pharmacists and pharmacist clinicians can play in combating the opioid epidemic. Certainly things like naloxone distribution, but beyond it, education of both the patient as well as the treatment community. Identifying high-risk patients. Pharmacists are often that first line of interface to pick up some non-reassuring or aberrant drug-related behaviors. And there's really exciting literature out there. APNs and physician assistants, right? Can do, certainly depending on the state, can do everything a physician can when it comes to buprenorphine prescribing. Certainly here in New Mexico, that is the case. Right? And all of these, the advanced practice providers, the physicians, are really going to carry out the physical examination, making sure the patient is appropriate for treatment and ensuring that the prescription is provided. In many of these modes, these models of team-based care, a key role that physicians have played has been training and education to the rest of the team. That's been one of the sort of the unique roles that physicians have been utilized in. This is a reference slide, comes from the Massachusetts Collaborative Care Models, which is one of the earliest models that was implemented. And it's interesting, Brandon, Dr. Warwick and I are both on this CDC-sponsored ECHO to combat sort of, and help communities when pain clinic or an addiction treatment clinic closes suddenly without notice because of DEA action. They sort of call us in and we work with those community. And currently we're working with, New England and Mid-Atlantic states. So in a lot of the cases that come up, including the case last week, they were utilizing this Massachusetts collaborative care model. It is still widely used in many parts of the country, and it was one of the first ones out there. And I took this as a reference from them, right? And this is something that, again, the team would do with the team lead, the clinic, the prescriber, the physician taking the lead and really making sure that this education happens. And for some stuff, all staff from front desk on should be educated, right? For example, basic understanding of addiction, of substance use disorders. I think that's critical for everyone to understand. Challenging behaviors, boundary settings. I would say creating an anti-stigma environment. That should be all staff, right? But then there might be some more specific things that, phone scripting, anyone who answers phones, right? For example. So I think there it is. And I mentioned the Massachusetts collaborative care model. So I will end with a note on that. It was one of the first team-based care models that was implemented in Massachusetts. No surprise there. And it was initially designed to improve access to treatment with buprenorphine, right? And the early data was extremely promising. There was a big education component, right? And through that education, they were able to increase waivered physicians. Remember, the data waiver, thankfully, is no longer a reality. It is gone as of this year, as of just a couple of months ago. Anyone who has a DEA license can, and I would say should, prescribe buprenorphine at this point. But back in the dark days of data waiver and shortages of people prescribing buprenorphine, this program was significantly able to increase the amount of physicians who were prescribing buprenorphine. And they significantly increased patients on another outdated term here that they had used, medication-assisted treatment. We've largely moved away from it at this point in favor of medications for opioid use disorder, especially minorities. And the model they used, again, was similar to what we've talked about. The team lead was a nurse, what they call a nurse care manager, and they paired up a nurse care manager with a medical assistant. And they found that this team of one nurse care manager and one MA were able to manage a load of about 125 patients. And it was financially viable and sustainable. And this was the flow, how it flew, right? So you can see that initially, when the patient sought treatment, the nurse care manager, this is a clinical function, would do an initial screening. Do they meet criteria? Are they appropriate? Just very cursory. Then the whole OBOT, standing for office-based opioid treatment team, would meet in a room once or twice a week, and they would review in more detail the charts of anyone who had been screened, right? And once that happened, if they seemed appropriate, the patient would be brought into the clinic. The MD at that point would have done the chart review. They would do a physical exam, make a opioid use disorder diagnosis, and decide whether it's appropriate to prescribe. Then the prescription would happen, and the buprenorphine induction really was protocol driven. So there was a fairly standard protocol. The nurse care manager would, kind of educate the patient how to do it. They would offer support, do phone check-ins as the patients got started on buprenorphine. And even the monitoring visits and follow-up visits were primarily done by nurse care manager. And then the MD would sort of provide backup. They would, of course, see the patient, check in with them. And this really improved access, right? So again, a perfect team-based approach where, limited resources were leveraged to improve access to care. And this is a reference slide that included what the screening assessment looked like. Importance of training. We want to always be thinking about building up capacity because there is such a shortage of providers, right, across in this field. So this, again, these are some of the things, just like we're doing in this Echo, and some tele email backup for consultative support are critical in this piece, because you want to be able to ideally build up capacity across the system. And making sort of public domain policies and procedures, guidelines, right? Clinical guidelines, documents, which can be adapted or modified, billing support, et cetera. And this is a reference slide again about what the core training entailed in this. And a lot of this is what we're doing actually here in our Echo Clinic. And finally, we're at 12:26. If there are any administrators on, I just kind of make this appeal, right? Make this plea. I do this because if you look at literature on barriers to why buprenorphine is not prescribed enough, oftentimes administration rises to as one of the top factors. In other words, if the administration is supportive and helps generate supportive guidelines, then buprenorphine implementation is much more likely to happen. Administration needs to be responsive to and supportive of the clinical team. I think this happens by regular meetings through open communication, ensuring there is adequate coverage, ensuring adequate appropriate staffing, allowing time for trainings and continuing education. That's key. If we're going to be treating patients to the best of our abilities with the state of the art, we want the trainings, continuing education to happen. Again, just builds up capacity, builds up that expertise and confidence, and helps generate policies and guidelines, in conjunction with the team. And lastly, what all of us can do, some really basic things to start with. I think being an advocate for our patients is always important, creating an anti-stigma, accepting, patient-centered environment, and really advocating. Policies matter. So really working with our leadership to really enact and support policies that are going to benefit our patients, such as funding for treatment, drug take-back programs, education, youth engagement, naloxone distribution, etc. And I will end it here. Thank you. And turn it back over to you, Dr. Warwick.